uppercut, and you handle it pretty well.
Thank you. I appreciate that very much. We got some work to do, but we're going to do it together. So I got a great team right here. And welcome everyone to the Insurance and Pharmaceuticals Subcommittee of the Health and Government Operations Committee. We are here today to talk about two bills. This is not a second hearing for a bill, but a work session. The process will be that our council staff will overview the bill for us, and then I'll give the sponsor an opportunity to speak briefly to the bill, and then we will. I know that if I know that there's some folks out there who have information, I'm going to be calling on them, but people are free to raise their hand in the raise hand panel if you have questions or comments about bills. So, and that includes anyone who was invited into the Zoom link. With that, we're going to start with House Bill 910, Health Insurance, Hearing Aids for Adults. Lisa Simpson, would you tell us about the bill?
Sure. So House Bill 910 requires carriers to provide coverage for all medically appropriate and necessary hearing aids for an adult covered under a policy or contract. Carriers may benefit to $750 per hearing aid for each hearing impaired ear every 36 months. An insured or enrollee may choose a hearing aid that is priced higher than the benefit limit and pay the difference in costs without financial or actual penalty to the hearing aid provider. The bill does not prohibit carriers from providing coverage that is greater or more favorable. And
AJ, I'm going to ask you to let in Michael Patty from MIA, Deb Rifkin. I think those are the two.
Yeah, they're joining.
Okay. Okay, Delegate Lasanti, want to speak to us for a moment about your bill?
Certainly, and thank you, Chair Cullison and members of the committee. I really appreciate the fact that you are hearing this bill today. Obviously, insurance coverage is outside of my subject matter expertise, so I leave that piece to you. And I note though that the Department of Health did offer support for this bill with amendments, and I do appreciate that, and I certainly accept any amendments that the subcommittee or the committee would deem necessary, because at the end of the day, this is about giving a minimal benefit to the hearing impaired. I think that we've seen so many stories of folks trying to navigate this everyday life, and particularly during this COVID, how very difficult it is if you can't afford hearing aids, and the ability to hear just segregates you from activity in daily life. So thank you very much for any consideration that you might give.
Thank you. Thanks for coming this morning. So I think I had asked the carriers to give me some information on what currently exists. So Matt Celentano, I see you there now. Matt, do you want to start?
Sure. Thank you, Delegate Cullison, for the opportunity. As you all know, carriers are required to cover all children hearing aids, and we've been doing that for a while. Our concern with this bill is that it's a mandate, and it will drive the cost of healthcare. Also, carriers in varying degrees are already covering adult hearing aids. Now, it is wildly varying by carrier and by plan. There are different schemes in which to require that beneficiaries can get access to hearing aids, as in there are some carriers that are full coverage. There are carriers that are utilizing discounts. There are carriers that are utilizing sort of third-party deals with distributors. I think that by having a mandated level in statute, that you might be putting in some of these approaches into jeopardy. And it also doesn't account for the technology that is changing and improving on a daily basis, and having a $750 level there could actually create a benchmark in which we could be going backwards at some point. So I think that there are already carriers that are trying to make sure that folks that need access are getting access, and by creating this mandate, you might actually have negative consequences.
Thank you, Matt. I'm going to let the carriers each say what they need to say, and then I'll give a chance for anyone who's here to ask questions of the carriers. So Debbie, you want to go next? Debbie Rivkin?
Oh, sorry, I was having trouble getting off of mute. So we agree with Matt that it's very difficult and not appropriate to put standards of a mandate into the statute because things change all the time and it takes away all flexibility. So we think that it's an inappropriate standard that we should ever put in law. It's a bad precedent. It had been done in the past on a couple mandates, and the legislature moved away from that approach because they recognized that it didn't keep pace with costs and technology and changes. So we think it's inappropriate.
Okay, thanks. Kim Robinson?
Good morning, Madam Chair, members of the committee. Kimberly Robinson for Cigna. We also do have some coverage for adult hearing aids and agree with everything that Ms. Rivkin just said in terms of putting something that is so static into the statute. Because this is a technology-driven space, we are certainly seeing different kinds of advancements and developments happening that's going to affect price point, that's going to affect what types of devices carriers are covering, but we provide under various benefit plans access to hearing aids through coverage. And for other plans, this is broader than just the fully insured market. We also offered access to discounts for other types of devices, and certainly we cover it in the Medicare space. So for that reason, we also think that it's probably not the best time to try to adopt a mandate, particularly when there's not a wholesale gap in coverage for consumers in the state.
Are there questions of the carrier? Please raise your hand in the using either your participant or your reactions button, depending upon which system you're using. Let's see. Delegate Karen Lewis-Young.
Thank you, Madam Chair. I'd like to ask the carriers if they have attempted to quantify the other health expenses related to being deaf and not being able to get assistance. I mean, I understand, or I wasn't surprised by your opposition to a mandate, but if ever there was a time, it would seem to me it would be now. And if ever there was an exception, it would seem to me it would be now, particularly for the elderly who are suffering from loneliness, isolation, and depression. Being deaf and unable to communicate heightens that. They also can't use technology because they're deaf. So when you're lonely, isolated, depressed, it affects your physical health, your mental health. So it would seem to me that an investment in hearing aids to allow someone, particularly the elderly, to be able to communicate would be a very small investment relative to the other health consequences of not being able to communicate with anyone. And I'm curious to know if any of you have explored that aspect of it, that relationship.
Delegate Lewis-Young, that's a really good question, and I think it's a conversation. I have not done an analysis of the associated costs with hearing loss, but as to this bill and what you speak to, that the elderly population that have other conditions that come along with this, Medicare covers hearing aids for the elderly. So this bill would not address this particular issue. If you have constituents that are having problems that are elderly attaining hearing aids, you should certainly send them our way. We can figure it out. But Medicare does cover hearing aids for the elderly.
Well, maybe I should rephrase it, approaching elderly or disabled.
I think that this is certainly a worthwhile discussion to have, but this is outside of the scope of this bill for sure.
Right. Delegate Krebs.
Thank you. I'd like to understand, again, the narrow scope of who this actually would include. The more I read it, sounds like, as you said, it includes, we already have it as an essential health benefit, I think, but it applies to a very narrow segment of the insured market. Exactly who would be included and who would be excluded, and what would the effect on the, I mean, is it really going to help anyone?
I feel like at this point, I should just replace my face on these screens with the pie chart of who these mandates actually cover. So as you all have been told and are aware of, that these mandates only cover about 17% of the insured lives in Maryland. And that's all that the MIA and the Maryland General Assembly has regulatory authority over. So although this would set a mandate and would ensure coverage at a certain level, it would only be for a certain amount of people, not you can't touch the self-insured, can't touch the Medicare folk, the Medicaid population. That would be outside of the scope of this legislation.
But it says in the bill, it's already part of essential benefits for, is it already part of the benchmark plan?
Children are already covered
Right.
across the board in Maryland. Yeah, children.
I thought I read somewhere in the packet that we couldn't discriminate because of age, and that was changed. Is that true or not?
That is not true. There is a mandate across the board in Maryland for children for hearing aids, but not for above 18 years old.
So the essential benefits cover just children. Oh, thank you.
Yeah.
Okay. I'd like to hear from the Maryland Insurance Administration. So is that Michael Patty or Di Reed?
Hey, Delegate Carlson. Yeah, I'm here.
Hi, Michael.
I don't think we have much more to add from what the carriers have already said. Our letter of information does really lay out how narrow this bill is. Sorry, I'm pointing at my screen over here, but the letter of information that we submitted for the hearing does lay out, how narrow it is, and it really revolves around the $750 limit and the 36-month time frame, and how that doesn't necessarily correspond with federal regulation. So while I'm sure Delegate Lasante's intent is to hit as many people as possible, this bill, solely under the way it's drafted, is very narrow, and I think the fiscal note highlighted that as well at the very end of it.
Are there any questions of the MIA? Are there any other further comments on this bill? Okay, seeing none. Is there anyone wanting to make a motion on this bill? All right, then we'll just hold this bill. Thank you, Delegate Lasante, for coming and for bringing and being concerned about our folks who are hearing impaired. I think one of the things that comes to me is perhaps we need to get the information out, and I'll call on the carriers to do this in a way that lets people know that this benefit exists, because I can tell you that I didn't know. So it would be helpful for people to know how to access the benefit.
I think every bit helps. I appreciate that.
Right. Okay. Thank you very much. That concludes the work on 910. We're going to move to House Bill 601, Pharmacy Benefit Managers, Definition of Purchaser, and Erisa. Lisa, you want to talk to us about this bill? And AJ, let everyone into the room now on this bill. Where's Lisa? There she is.
So House Bill 601 repeals the inclusion of ERISA plans from the definition of purchaser as it applies to Title 15, Subtitle 16 of the insurance article, which is the title of the insurance article that governs pharmacy benefit managers. There is an amendment that I also sent around that Delegate Kipke is proposing. The defines pharmacist service and expands the definition of purchaser to include a plan or program that reimburses, covers the cost of, or otherwise provides for prescription drugs or pharmacist services to individuals who reside in or are employed in the state.
Delegate Kipke, you want to speak to your bill?
Yes, thank you, Madam Chairman. So there was a Supreme Court decision recently that allows states to regulate PBMs regardless of the payer. So as we all know, a lot of the things that we do only impacts the individual group, and it only impacts like 20% of the market. The Supreme Court said the laws that we've passed as it relates to PBM can extend to what has been previously Erisa exempted. So the Maryland Attorney General, I don't know if you can see this, signed on, there's Maryland. Brian Frosch signed on in support of the case in, I forget what to say, Arkansas.
Arkansas, right.
And they are one of the bigger advocates for this bill, aside from obviously the independent pharmacists who are very supportive. So over the last few years, we've been passing laws that say to the PBMs, if all these different schemes that you come up with to reimburse folks, we've put into law the way that can go down to sort of protect the independent pharmacists that have been asking for help. We don't require any particular reimbursement, but we sort of create a framework for what that reimbursement has to look like, with the goal of at least making sure that reimbursed for the actual cost of the pharmaceuticals. So what this bill does with this amendment is it modernizes our code to take full advantage of the recent Supreme Court decision, and it would apply to all payers in Maryland. I believe, Madam Chair, although I can't see, but I believe David Kahn might be with us. He is the outside counsel for Epic. I'm not a lawyer, he is, and he's probably in the best position to explain to us the legal aspect of all of this. But I'll just conclude with this. This is a very simple bill. This is not a complicated bill like some folks may try to claim. It's passing around the country like wildfire. And it's a very simple thing that we can do to extend the full protections of existing Maryland law to all of the different types of plans that are offered in Maryland. So with that, if it's all right with the chairman, I'll ask David Kahn for his explanation as well.
Thank you, Delegate. And yes, but before, Mr. Kahn, before you speak, I'm going to ask Delegate Karen Lewis Young to please mute your screen. So David Kahn, you're going to help us completely understand?
I'd like to. Unfortunately, I'm having some audio difficulties. Can you hear me?
Yes, we can.
Okay. So I missed the lead into exactly what I was being asked to address. You mind?
Let's put this in.
So could somebody mute Delegate Karen Lewis Young?
I think I just did. I hope I just did. Okay. I'm sorry, David. Go ahead.
David, I was just asking for you to provide some clarity. Obviously this is a very simple bill. Opponents of the bill have tried to, I think, confuse things. And if you could just explain what the bill does and why it's necessary. Thank you.
Well, I agree it is a very simple bill. The Supreme Court in the Rutledge decision opened the field to the states to regulate PBMs without reference to the type of payer at issue. And this bill simply redefines payers to make sure that can you hear me?
Now we can.
The law applies equally to.
We lost you. Okay, I'm not sure. While he's, okay, I'm not sure we're gonna be able to have the benefit of his expertise. I'm sorry. If Mr. Khan, if you want to try calling in, I think there was a number associated with the link. AJ, do we have a telephone number that we can give Mr. Khan? Wait. No. No telephone number. Okay. Well, okay, we try now.
I'm still here. My problem is that my audio, I hear a dial tone. It's like it's trying to call in that way. So the
Okay.
audio is not working properly.
Yeah.
So I'm not sure what you heard from me, but the Rutledge decision, as I said, is quite simple. It allows PBM regulatory bills to apply to all payers, regardless of whether or not they're employer-based groups.
I have a question before I open it up for other questions. In the decision, did it allow for regulation beyond rate setting and beyond reimbursement rates? So did it allow for total regulation of PBMs? No matter the payer.
Madam Chair, since David's having so much trouble, I think Jim Doyle is on as well. I know he's taken some time to understand.
Okay.
Also, Patricia O'Connor is with the Attorney General's office.
Okay.
And since they filed an amicus brief, I do believe they have a very good understanding of this.
Thank you, Delegate. Let's go to Pat O'Connor and Pat, can you answer my question in terms of the scope of regulation that was allowed by the opinion?
Morning, Chair Cullison. Unfortunately, I'm not prepared to do that.
Okay.
What we did previously when we submitted some language, an amendment, was we consulted with the MIA. We have not conferred or consulted with them regarding this amendment, that is the sponsor's amendment, but we agree that the definition, which would make a purchaser include Erisa plans, we agree with the intent and that it will give full force and effect to Rutledge. So I'm not prepared to go into the nuances of Rutledge. I read it several weeks ago and I would be loath to give misinformation.
Well, I appreciate that, Pat. Mr. Doyle, do you have more information on this in terms of the scope of regulation?
Now, can you hear me?
There we go. Yep.
Okay. Well, I think it's been explained to a certain extent at this point. Attorney General Frosch filed an amicus filing with the Supreme Court saying, in effect, we want the court to give us the authority to regulate PBMs more than they are now. And in that amicus filing, Maryland and the other states that joined in that cited specifically to the unfair advantage that PBMs have because they own their own retail pharmacies and mail order pharmacies, and to the self-serving interests that they have in protecting their own affiliated entities, insurers and retail pharmacies, et cetera. So the Supreme Court did exactly what Attorney General Frosch and the other attorney generals had asked for and gave this expanded authority. Now, in terms of what the authority was given, the court made it clear that This applied to, I think, authority across the board, even including those cases, those Erisa cases, which up till then had been sort of off base. You couldn't really touch them. And the Supreme Court said, no, you could. Now, there are some gray areas as to exactly where that might fall, but clearly from the court's language in which they've used in that case, if I can just pull it out. Actually, I can't find it when I need it, but basically they said that the states had the authority to regulate PBMs as long as they were not intruding on a central plan or a national plan of the PBM, and that was not limited solely to cost regulations. As a matter of fact, they cite an earlier Supreme Court case from years ago in which they allowed indirect costs even to take effect. The concurring opinion is also interesting, which is basically saying, look, if you look at all the case law of the court, the Supreme Court has not overruled these kinds of cases unless there's really a conflict between what the state authority says it wants to do with the PBM and what the Erisa plan specifically allows. So I think that a fair reading of the case is that unless there is that kind of conflict between what the state wants to regulate and what Erisa specifically allows, I think those are areas where the court is going to say that's fine regulation. You will get to some gray areas, obviously, on the borders where there's some dispute about that. But the point is that I like to make is that, again, the Attorney General of Maryland has asked for this kind of broader authority along with many other states. The Supreme Court has given that. And unless House Bill 601 is enacted, the Rutledge decision will not mean anything in Maryland because of the statutory prohibition, the statutory definition of what a purchaser is. And a purchaser under the Maryland statute basically excludes Erisa plans. So it's fine for Rutledge to say, yes, those plans can be regulated, but as long as the Maryland statute says they can't be, then there's really nothing for the Rutledge decision to do. And it was all kind of a waste of time for Attorney General Frosch to go in there and sign on to this brief. So Rutledge was a good decision. It gives the state what they want, and but it needs to be implemented with the statutory changes in order for Rutledge to really take effect.
That makes it very clear. Thank you. I mean, the part that can be clear, I understand there are gray areas around the regulation piece. Michael, do you want to speak to the bill at this point?
This is Mike Johansson. Can you hear me, Madam Chair?
Okay. Yes, I can.
Okay, so if we could have Lauren Rowley from PCMA go first, and then I'll add a couple extra comments.
Okay, so
Lauren's on.
for those who are new to the committee, these are folks who represent PBMs. So
The Pharmaceutical Care Management Association, Madam Chair.
right. Is Lauren in the room?
Yes, I'm here, Delegate Colson, and I apologize. I'm not sure why my video isn't on, but yeah, I think, actually we agree with some of what the previous presenter said, in that the court did actually say that the states have the authority to regulate rate regulation. But I think it's important to take a step back and realize what the question to the court was. And the question to the court was, is the Arkansas MAC law and the refuse to dispense provisions preempted under ERISA? And the court said, agreeing with a decision they made 25 years ago in Travelers, which I think the previous presenter also noted, that actually rate regulation is allowed by state regulatory authority. The court did not say that other additional laws on PBMs would not run afoul of ERISA. It did not overturn or invalidate previous decisions that it had made regarding ERISA preemption. And it actually said that these laws, especially the Arkansas law, if a state was to pass something very similar, would lead to higher costs for ERISA plans. So while we agree that the court very definitively said that rate regulation is within the authority of the state, we believe that this bill seeks to go much further and much more broadly than that decision allows. And I think it's also important for this committee to understand that the NEIC, the National Association of Insurance Commissioners, is going to be looking at this. We had a discussion last week on their PBM model that's soon to be voted on. And part of that discussion obviously led to a discussion about what Rutledge does and does not say. And I believe that there is some gray area that the commissioners, including Maryland, I'm sure will be involved in that discussion over the course of the next several months of what regulatory authority Rutledge actually provides to the state. We believe it's very clear that it's upholding the traveler's decision of rate regulation, and that anything further than that could run afoul of ERISA preemption.
Okay.
Madam Chair.
Michael?
Yep, just to follow on and not to repeat. So the way this bill is drafted, it would presumably affect all of Title 15, Subtitle 16, which is the PBM law. There are clearly things in that subtitle that are not rate regulation. There are clearly things like the MAC pricing section that is rate regulation. And then there's a number of provisions that could be rate regulation or maybe aren't rate regulation, and no one knows yet. Secondly, in the Arkansas law, the General Assembly said, we want to apply this MAC pricing rule to ERISA plans. They, proclaimed it as part of their legislative process. It therefore gave ERISA plans and those who would be affected a chance to engage in the legislative discussion. This particular provision in this bill here basically is bringing in ERISA plans, okay, and the possible impacts on them without giving them the benefit of an understanding of what the impacts and costs are. There's nothing in the fiscal note that evidences how the MAC pricing rule may impact ERISA plans, because it wasn't in the fiscal note when the MAC rule was passed, because this section didn't apply to ERISA plans. The GER regulation, the regulation that says you can't have a downward adjustment in a performance plan. Those provisions, if they were passed as legislation with the bills saying on their face these would apply to ERISA plans, would give the ERISA plans a chance to decide whether or not they are comfortable with that impact. Lastly, the specific language of this amendment has some language that I think causes an additional problem. It basically says that pharmacy services under this law are those that are provided to individuals who reside in or are employed in the state. So if you reside in Montgomery County, you work in the District of Columbia, your insurance contract for your employer in the District of Columbia is written under DC law, this seems to say that you're still affected by this particular bill because you reside here. So I think there's some implications of this that are very extraordinary. I think Lauren mentioned this is a matter that's going to be looked at nationally by the Association of Insurance Commissioners to understand kind of more globally what the impacts are. And we would recommend that this is a bill, and I'm not suggesting this just to get us out of this conversation at the moment, but this is a bill that has implications that should be looked at over the interim. Thank you.
Thank you. Michael Patty from MIA has information for us.
Sure. Thank you, Madam Chair. I just want to confirm that the MIA is a member of the NEIC work group, the NEIC PBM work group. So, we are involved in those discussions, working towards a model. Maryland is, very far ahead as compared to other states in regulating, PBMs. I didn't want to comment so much on the amendment language, but now that it's clear what the amendment language is trying to achieve as it relates to Title 15, Subtitle 16. The MIA does not have a dedicated PBM branch of our life and health team. So as this bill is considered, the MIA does expect to have an influx of plans filed with us that need to be reviewed for compliance with the law. As Mr. Johansson said, we're still reviewing to see which subparts of Title 15, Subtitle 16 would apply to these, Erisa style plans. We have to review and make sure those plans comply with the law. We would probably be looking at having to add another analyst to handle that increase in workload. It wasn't reflected in the fiscal note because as drafted, we weren't clear with what the intent of the bill was, but now knowing that, we just wanted to get ahead of that and let the committee know that, this would be a bill that would certainly impact the workload of the MIA. And having said all that, in the event that, this bill were to be moved to a discussion over the interim, the MIA is always available to participate.
Okay. Thank you. Kim Robinson.
Thank you, Madam Chair. I just want to hone in on one of the points that Mr. Johansson made. And this is, I think, relevant to the point that Mr. Patty just made about the scope of review that this would trigger for the department. When you look at traditional insurance contracts, they are typically enforced based on where the contract is situs, meaning that if my employer is located in Connecticut, our benefits are governed by Connecticut law, and that's going to govern regardless of where the employees for a large self-insured employer live. That's going to be, consistent benefits generally for them throughout the country. I know that Delegate Kipke took the language that he's proposed from the Arkansas law. This was not a point that was discussed in Arkansas. I checked with my teammate who handles Arkansas. They were focused really on the ERISA preemption question, as opposed to some of the other details in the bill, and in particular that language about where someone is employed or resided. But what it creates then is this conflict of laws. As Mr. Johansson mentioned, right, we live in a very compact metropolitan area where people may live in any one of a number of states and work in Maryland, or be employed by a large Maryland employer and live anywhere in the country. And so what we do in the large group insured market is we focus on just where that contract is cited. And if every state only handles those contracts under, written in their states, it makes it clear who's got control. Otherwise, what happens is you begin to have these conflicts where one state says, we control those contract cited here. Another state says we control the people who will live here. That person is now subject potentially arguably to two states' regulatory schemes, and it's not clear who controls. And so, the NEIC has worked very hard on the contract side to say, if we follow the contract, everybody's lines are clean. So that language definitely causes a concern just with the conflicts of law, which was not contemplated when Arkansas wrote it. I think also, Ms. Raleigh made the point that when we talk about what the scope of the decision is, you have to, again, look at that scope of the question. And the question was limited to what was in Arkansas Bill 19. And we completely agree with Delegate Kipke. The Supreme Court absolutely gave you the right to regulate those things that align with the topics of Arkansas Act 900. But our law is far more expansive than Arkansas's law, and it doesn't completely align. And so I think, our opinion is that you absolutely can choose to codify Rutledge. We believe that you ought to for clarity, limit what you're doing to those provisions that align with Arkansas Act 900 when you choose to make this decision. Unfortunately, because our session came so quickly on the heels of the bill, there's a lot of analysis happening nationally about this. I've seen a lot of states introduce it. I haven't seen a lot of states act on it yet. I've seen some states choose to defer for the year because they wanted to make sure they understood what their scope was, and they are leaning on the NAIC to do that. And for instance, Maryland requires the filing of these contracts. That's not in Arkansas Act 900. And for Mr. Patty, if you write this for everyone who resides in the state, it means every national large employer who has a single employee who happens to live in the state of Maryland would now have to file their contract with the MIA. And I don't think, given 6 million Marylanders, that anyone has an idea of how many contracts that's going to mean for the department. And so those are those kinds of important nuances that even as you move forward with taking the authority you're entitled to are really important to work out. And so I think there's ways to start to get the amendment closer to what the Supreme Court decided, Delegate Kipke. I don't think your amendment is there yet. So I do think that there's more work that just needs to be done to make sure that what Maryland is doing is what's really in its hands.
Michael Johansson?
Just a quick comment on scope. Just rereading the amendment. This amendment would apply now for the first time, the PBM laws to every local pharmacy plan. So local governments, municipalities, school boards, other things broader than the state employees health plan. So it's not just Erisa plans, which are typically private sector plans, but the plans that are, local counties and others, which are kind of just PBM plans, they aren't run through insurance companies. This would now pick them up for the first time. So if you go back to the concept of when we've talked about the impacts of certain of these provisions over the last couple of years, have any of the local governments had a chance to say whether or not they agree with the impact and what the consequences are? So thank you.
I see Mr. Khan's hand. David, you want to?
Can you hear me now?
Well, I can.
Good. I apologize for the problem earlier. The points made by PCMA are quite interesting, but really evade the issue at hand, which is the PBM law regulates PBMs. The definition of payer is relevant to what types of contracts that PBMs have that are regulated by the law. The Supreme Court decision said quite broadly that the Arkansas law doesn't act on Erisa plans because it applies to PBMs whether or not they manage an Erisa plan. Indeed, the Act does not directly regulate health benefits at all, Erisa or otherwise. It affects plans only insofar as PBMs may pass along higher pharmacy rates to plans with which they contract. The decision goes on to discuss the spread that PBMs receive, and the fact that they don't, what they pay pharmacies isn't what actually they charge to plans. This statute regulates the PBMs and attempts to address their practices. It doesn't regulate the self-insured plans. And this amendment would make it clear that the PBM law applies to PBMs regardless of what type of plan they are handling the pharmacy benefits for their own purposes. I want to make sure that point is not missed in the flurry of arguments that we've heard here.
Okay, thank you. Kim, you have a response?
Just one clarification, and if you look directly at the language of the Rutledge decision, the court says one, again, I think you cannot overlook the fact that what the court was evaluating was the Arkansas law, which does not parallel Maryland's law, which is 24 statutes in 6 different parts that do a variety of different things with regards to PBMs. There is a part that focuses on rate regulation akin to what was in the Arkansas law, and the court is focused exclusively on those types of provisions. It speaks to rate regulation throughout the bill because that is the entire scope of the Arkansas law. It was only focused on rate regulation. And in making this decision, the court even says, and this is a direct quote, in sum, Act 900 amounts to cost regulation that does not bear an impermissible connection with the reference to Erisa, because the decision is focused on, in fact, cost regulation. So to the extent that what Mr. Khan just said speaks to those provisions of Maryland's law that are about cost and rates, completely agree. To the extent that this bill, because it's changing the scope at the top of the title for all pieces of the title, go beyond cost regulation, we would dispute that the court's decision automatically opens the door for the other parts of Maryland's law. And again, believe that an amendment that narrowed it to cost regulation would absolutely align the law with Rutledge.
Okay. I'm going to go with Mr. Doyle. And while Mr. Doyle is talking, if there are questions from the committee, think about that and use the raise hand function to let me know that. So Mr. Doyle.
Yes, I just wanted to, and can you hear me? Am I still?
We can. Yep.
I just wanted to address the last point, and it's been raised a couple of times. Yes, the Arkansas law in that particular case did deal specifically with cost because the PCMs or the PBMs challenged the law that said you at least have to reimburse the pharmacy for what they paid for the drugs. And they challenged that. They didn't want to do that. So the Arkansas law itself did deal with cost, but the language of the Supreme Court and what in terms of what they talked about, the scope of their decision, goes much broader than simply costs. They, for example, say in their opinion that what the court is going to do is ask whether a state law governs a central matter of plan administration or interferes with nationally uniform plan administration. That goes well beyond cost, and that can deal with all kinds of things. And it can deal with many things where, frankly, there is no conflict between what the state may do with the regulating a PBM and what Erisa specifically allows. Again, I'll go back to what I say. I think the court's decision is in terms of what they actually stated, goes well beyond what that Arkansas law happened to deal with. And that's not unusual. So the court dealt with a cost provision, but in its language, it made it clear that unless there's some conflict between the state law and what the national Erisa plan is requiring or dealing with, that unless that's occurring, you're going to have the authority to regulate. So I think it's completely erroneous to try to narrow the scope of Rutledge in the way that the opponents are doing.
So, are there any questions from committee members? I have a question, and this is for Mr. Patty. Can you tell the subcommittee what the role of NAIC is in general?
Sure. So the NAIC is comprised of all state insurance commissioners and territory commissioners. Whenever, the role is obviously to create model language that can be adopted uniformly throughout the states. We've seen this in a lot of financial solvency among states. The PBM space is quite new in the sense of the NAIC taking on this responsibility. There is draft model language, so this isn't just, it started yesterday. This has been an ongoing process. It does take time for the NAIC to get all state insurance commissioners on board with uniform language. Typically, in terms of process perspective, the NAIC will have model language over time that could become an accreditation requirement. It's too early to tell if this kind of licensing and PBM regulation model will get there. But like I've said before, the MIAs, the state of Maryland's already, very far ahead. We're already doing things that I believe that the model isn't covering. or the discussions haven't been there yet. But, we can certainly keep the subcommittee and the full committee up to date on, how the MIA is interacting with other states as it relates to this model in particular. But it is a very in-depth review. The stakeholders that you're hearing from today are involved at the national level as well. While Maryland's not the chair or the vice chair, we are very involved though.
So just to clarify, these are state level commissioners that are essentially apolitical and are not connected and regulate the health insurance industry.
Correct.
Okay.
Correct.
So I want folks to understand the nature of the group that's working on this. Delegate Krebs.
Thank you. And I appreciate having legislation. However, this is not very complicated. This particular piece of it, there's other pieces we're going to have to do as we go down the road. It's just basically allowing the legislature, as I think Mr. Doyle on, to be able to take away the prohibition that we already have of who we are able to regulate. So I don't think this is earth shattering. It's a policy decision we've discussed ad nauseum for years and years. Mm-hmm. And basically the Supreme Court decision has now cleared that away for us to make this decision. And we're not, this is just one little piece of allowing us to do it. There's other bills and other things that we're trying to actually put these things in place. So I don't think that, I'll go back to the maker of the motion. I don't think it's a controversial, if they're going to wordsmith the language in a model piece of legislation, I think this pretty much, our staff is pretty in tuned. I believe our drafting staff is very qualified, and it's not that difficult to what we're trying to accomplish. So if they're okay with it, I'm fine with it. I don't think we need to wait on this issue for them to come up with model words. Maybe our words will be model when they meet. We can say, hey, here's our model legislation. So I'm not concerned about waiting another year now that we finally have the Supreme Court decision.
Okay, so I have 3 more hands, and what I would like to do is hear from these three folks, Mr. Doyle, Mr. Johansson, and Ms. Robinson. And I'd like to invite MIA and a representative of the carriers and the sponsor of the bill to meet between now and next Tuesday to see if there's any language that we can get to some of the concerns that have been raised today, and we'll bring this back next Tuesday. So we need to have that meeting in time for us to have a report back out for the committee next Tuesday. So then I have Mr.
Thank you, Madam Chair. The Supreme Court said that states may enact laws dealing with PBMs with respect to rate regulation. The Supreme Court then reminded itself and everyone reading the opinion that ERISA on its face says states can't enact laws that deal with plan administration. So when all that language is in the Supreme Court decision related to plan administration and things broader than rate regulation, that's just a reminder of the existing ERISA prohibition. So nothing that the Supreme Court said and nothing that the state of Maryland can do can override the ERISA provision. Secondly, while this amendment and just changing the definition of purchaser looks rather straightforward, it's the consequence is when you change the definition of purchaser at the beginning of this subtitle, are you the General Assembly saying that each of the provisions of the subtitle apply to all the PBMs? Has the subcommittee, had a discussion about each of the provisions of the subtitle? Does MIA think it can actually enforce each of the provisions of the subtitle? And I will suggest to you, there are some that are clearly plan administration. So even if you say you're regulating them, you can't because of the ERISA law still stands. There are some that are clearly rate regulation, you probably can if everyone has a sense of what the impacts are. And there are some that I don't think any of us would ever agree at the moment, whether they are plan administration or rate regulation or a combination of both. And I think that's the analysis that the MIA, perhaps the Attorney General, all the parties, and the NIC are going to talk about over the next several months. It is simple to say what they're trying to say. It is understanding the consequences that's the complicated part.
Okay. And the final part is going to be Ms. Robinson today.
Thank you, Madam Chair. Mr. Johansson actually said much of what I was going to say. I think Mr. Patty even referenced the fact that the department was still looking at all of the provisions of the PBM law, now understanding that this is changing who a purchaser is for every single provision, because they're looking as well to analyze how this aligns or doesn't align with the Supreme Court decision. To Mr. Johansson's point, there are clearly plan administration provisions that are part of our PBM law, absolutely reasonably so for the traditional scope of purchaser. There are clearly those that are rate regulation that I think if you wanted to move forward, you could draft the amendment to address specifically. But the way that the current bill and amendment approach this is at its broadest point, which I think frankly invites unnecessary disruption and challenge, and certainly is what's going to bloat the fiscal note for the MIA, as opposed to if you were to be a little bit more surgical about it. And I think that's the conversation worth having. And so I'm sure that either myself or certainly PCMA will be part of that conversation that you invited everyone to before the week is out, Madam Chair. I think that's really important.
Great. Thank you. Thank you all. Thanks for this great conversation. I think we all know a lot more about Erisa, and it's so glad to hear that Maryland is on the forefront of, trying to make sure that our PBMs are regulated and are looking out for our constituents as well as our pharmacies. So,
Madam Chairman,
Delegate?
Brian was trying to speak earlier. And
okay. I'm sorry, Brian. I didn't see your.
He didn't put his hand up, so he must not know the.
I've looked for the little hand up icon for a while, but I haven't been able to find it on my screen here. So
I see you haven't been on Zoom enough.
Use a lot of these platforms.
All right, Brian. I'll change my mind, and you can have the last word today.
Thank you. I appreciate it. I think that the other thing that we need to remember is the laws that we've passed as far as PBM regulation were not done in a vacuum. They were done to solve specific problems. And each time we came before the committee or the subcommittee, we were told, well, this really only affects 20% of the plans. You're not going to be able to affect all the other plans. We're going to be able to continue to do these bad deeds in all of these other plans. And, basically there's nothing you can do about it because of Erisa. Finally, we've gotten some clarification that that's not the case. We'd like to just make sure that the good work that this committee has done over those years does not simply apply to 20% of the plans, but applies to all of them as it should have from the beginning. This Supreme Court decision was not as narrow as they would like you to believe. The language that was used in that decision, the opinions, both opinions supporting the decision, was significantly broad and did bring into account the fact that it won't just be rate regulation that these laws will impact. So I think that the committee has done a lot of good work over the years, and we'd like to see that come to fruition to put a stop to some of these practices that are happening.
Okay. All right. Thank you very much. We'll be sending out an invite to folks to send a representative group together and try to set something up later in the week for us to kind of meet and see what we can come to on this bill. With that concludes our work today. Thank you all very much for your time. And HGO will see you at 1:30. Good afternoon.
Thank you.